Hi, Anita.
Good afternoon, sir.
Am I audible? Yeah, Anita, am I audible?
Yes, sir. You're audible.
So can you just allow me to start my video?
Just a second, sir. We are giving the access. Just give me a moment.
Yeah,
Sir, can you try sharing your video now, sir? Is it coming?
yeah. Am I visible now?
Yes, sir. Yes, sir. You're visible.
That's great. Thank you. Thank you. So what I will do is, Anita, that I'll share my screen once. Okay.
Sure, sir.
Just tell me if I can share my screen now.
Yeah, sure, sir. Pauline, could you please stop the screen which is already being shared so that doctor can share it now?
So is my screen visible, Anita?
Yes, sir. Your screen is visible.
Anita, am I audible? This is Dr.
Hi.
Vikas here.
Hi, sir. Hi, hi. Good
Hello,
afternoon.
sir. You're audible, sir.
Hi, good
Welcome.
evening.
Yeah, I
Hi,
can.
Saurabh.
Hi,
How are you
sir.
doing?
Good to have you, sir. Good to have you.
Thank you. Anita, please allow me as well to open the video.
Yeah, just a second, sir. We are sharing the access. Give me a moment.
Thank you.
Today actually we are abhi achanak suddenly we had a call that we are actually planning to start the bone marrow transplant program here. So hi sir, Vikas sir.
Yeah, I can hear you.
Yeah. So basically that's been given by some CSR funding and all. So
Okay.
they just asked us to send a video. So we are suddenly they said we need a video of the area and of your building, of the facilities. So we were just doing that, and then the other people are continuing. So I just joined.
Sure. I understand.
Yes, yes, yes.
Thank you.
Today, what?
That's a wonderful news.
Thank you. Yeah, thank you, sir. Thank you. Actually, at least we should be able to start the autos in a couple of months, and LOs probably in next 1 year and all. That's what we are planning.
That's wonderful.
Thank you, sir. Today you have OPD, sir, today?
I was in the hospital, decided to come back early.
Thank you, thanks. So Anita, did you allow sir to share his video?
Yes, sir, it was done, sir. Because, sir, could you please try sharing your screen also to have a
Yes.
check?
Yeah,
Oh,
yes. I can see you,
is
sir.
it dark? Do I need to
Yeah,
change the
yeah.
background?
Yeah, sir. It will be better if it can be just bit of bright.
Okay, sure.
Yeah, that's great now. That's good.
Is it better?
Yeah, yeah, much better, sir. Much better.
All right.
Sir, we will wait for some 5 more minutes and
Sure.
then we will start.
Yeah.
So Anita, today how many registrations we have?
Sir, we have around like 380 registrations, sir. Even like few minutes before the webinar also, people are like registering. So
That's
final
it.
count, I'll check and I'll let you know, sir.
So has Dr. Soumya and other discussants joined?
I'm checking, sir. We have given them a reminder as well. They told they will be joining in few minutes.
Okay.
Yes, sir. They are joining, sir. They are joining.
So if Dr. Soumya has joined, then we can actually, yeah, he is there. Hi, hi,
He's-
Soumya sir. Hi, hi. Are you there?
We are changing Soumya sir's access, sir. Just a second, sir.
Yeah.
He will be able to speak now. Yeah.
Thank you, Saurav.
Hi, sir.
Hello, Dr. Vikas as well.
Hi, Swami. How are you doing?
I'm doing fine. I'm doing fine.
Good to meet the Bhuvaneshwar team.
Yeah, thank you, sir.
Sir, we were all there together. I mean, when initially when I joined, Dr. Soumya had started the department.
And
So now they have a very successful DM medical oncology program which is running, which is the only program in Odisha, in fact.
I'm aware of that, and that's a very that's wonderful. And I think these are the efforts which are required.
So,
That's nice.
Thank you, sir.
so you have 4 residents, no, per year now for Dr. Soumya?
Wow.
Yeah, we have got
Congratulations.
four in each year.
Wow. Congratulations. Very good.
Thank you.
Yeah, yeah. That's very
हमारा
good
भी
news
सर-
here.
Yeah, sir. हमारा भी एक program approve हुआ है, but that is only for 1 DM per year because it's a combined department, medical oncology, hematology, and pediatric oncology, everything clubbed under one. So we are sharing the cake, and that's why it will have.
Yeah, but great. I mean, great start. I mean,
Yes, sir.
we'll have more people in.
Can you allow me the video? I'm not able to open on the video.
Yeah, doing it, sir. Doing it.
Will anybody else be presenting before me,
No, sir.
or
Nothing, sir. Mainly it will be like the flow will be like I will just make a brief introduction. Dr. Soumya will introduce you, then you have the talk. That's all. And once the talk is over, there will be some discussions. We will discuss those cases, if their doubts and queries with you. That's all. So you have the only presentation. That's all.
all right? So is it okay if I share the screen and do that, or maybe I'll wait for
Yes, sir.
I'll wait for Soumya to
Yeah,
take
yeah.
over. Yeah.
2-3 minutes. Okay. So let us.
Thank you.
So I think we'll start now, Anita. With your permission, Dr. Soumya and Dr. Vikas, we should start now. Okay, thank you. So, Anita, you there?
Yes, sir. I'm there.
Okay, so let us start now. Okay.
Yeah, sure, sir.
So good afternoon, everyone. And on behalf of the Department of Medical Oncology, Hematology, and in association with the International Association of Oncology, which is a non-profitable, non-charitable organization, we welcome you to this continued medical education on cancer-related anemia, the current knowledge and approaches to improve the patient-related outcomes. This is an important topic. And today we have our keynote speaker, Dr. Vikas Uswal, who has joined us already. And although our distinguished guest, Prabodh Das, sir, who was the head of department in our at AIMS Bhubaneswar, he has been unable to join us. So basically what our program flow will be, Dr. Soumya Surat Panda, he is the professor in the Department of Medical Oncology at IMS and Sam Hospital, Bhubaneswar. He will introduce our keynote speaker. After that, after keynote speaker will deliver the keynote speech, and after the keynote speech is delivered, that will be the topic will be discussed by all our discussants. So we have alumni and dignitaries and faculties from all across reputed institutes in Bhubaneswar, and we have Dr. Soumya Panda, Dr. Asutosh, he is an associate professor in the Department of Medical Oncology Hematology, AIMS, Bhubaneswar. We have Dr. Priyanka Samal, she is the professor, Department of Hematology, IMS and Sam Hospital, Bhubaneswar. We have Dr. Prashant Kumar Parida, who is an associate professor, Department of Medical Oncology, Cuttack. We have Dr. Jogmaya, she is an assistant professor, Department of Medical Oncology, KIMS, Bhubaneswar. And we have Dr. Biswajit Bhunia, who is assistant professor in clinical hematology from KIMS, Bhubaneswar. So after these discussions discuss their cases, all others, they can share their questions in the chat box. In fact, as the program goes on, as the speaker presents his topic, you can all put your questions in the chat box, and in the end, after the topic, we will discuss and take your questions one by one, and your questions will be taken up by the chief speaker. So without much delay, I would now request Dr. Someswara Panda to please introduce the chief speaker for today. Over to you, sir. I'll stop.
Thank you, Dr. Saurav. So I think I am privileged to introduce Dr. Vikas Oswal, and who has been on the forefront in the gastro-oncology in whole India and also outside India. So thanks to Dr. Vikas for being here, and I'll introduce him for all of you, those who don't know. And Dr. Vikas Oswal is a professor in medical oncology, and he started his profession by joining MBBS at Vijay Medical College and Sasson Hospital, Pune, as a medical college student. And following his MBBS, he completed his MD in internal medicine at the Lokmanya Tilak Municipal College and Hospital, Mumbai. And after successfully completing his MD program, he completed DM Medical Oncology program from TMH, Mumbai. He is currently a professor in the Department of Medical Oncology, TMH, Mumbai, where he leads the GI disease management group. And he has many publications in the reputed national and international journals. He has conducted and currently involved in clinical as well as translation research in GI malignancies. He is the General Secretary for the Indian Association of Supportive Care in Cancer, an affiliated unit of the MASC. So it is my privilege and proud moment to have Dr. Vikas Oswal in our group. So I request sir to give his talk for the audience. Thank you.
Thank you, Dr. Panda, and thank you, Bhubaneswar team, for inviting me. And this is a privilege to be here. I'll be sharing my screen. Is my screen visible?
Yes. Yes, sir, it is visible.
All right. So we'll be talking about the topic cancer-related anemia, and usually the supportive care is not something which is looked at with like great attention, and especially when we are in the era of immunotherapy, we by and large neglect supportive care because we think immunotherapy has lesser side effects. But as we move on, what happened to the targeted therapies? Immunotherapy is also showing us the same thing. The chemotherapy is the base and would remain an essential part of the treatment. And I will not keep going into the details of certain basic things, but I want to highlight one thing here is when to transfuse a patient with a cancer-related anemia. And usually grade 3 is something which is hemoglobin less than 8 and transfusion is required. Most of the guidelines, including the MARCS guidelines and multiple forums talking about the supportive care, they do not recommend a particular cutoff of hemoglobin for the transfusion. It entirely depends on the treating physician, the oncologist, taking care of the patient during the chemotherapy. It could be pre-chemotherapy anemia, or say gastric cancer coming with hemoglobin of 6 or 7 or something like that. It's a judgment of the treating oncologist when to transfuse. But usually below 8 is the cutoff which is considered for transfusion. There is a great amount of data to say that there could be a poorer response to treatment if the hemoglobin is low. There are many studies, but then there is a lot of controversy about it. Moving ahead, possible causes. Most common cause in our country is nutritional anemia. And as I treat GI cancers, we definitely see a lot of add-on nutritional deficiencies, iron, B12, folate deficiencies, and we do see that commonly that women in our country definitely have iron deficiency. Then blood loss anemia, as we commonly see gastric cancers or colorectal cancers, especially right-sided, may present just with anemia and they're investigated for the same. Functional deficiency is something which we usually deal with during our treatment, say cancer-related anemia, where anemia of chronic disease. And this part has been kind of neglected in our oncology forum, because I'm comparing with the CRF, chronic renal failure patients, and they do pay attention a lot to this, but we do neglect. And there are multiple other minor causes which we may not discuss this time. If you look at the incidence and etiology, they're common, say above 60%. And I was just looking at the literature because I was also planning a study. So there is no literature from India talking about, a large study to say that what is the actual incidence of anemia, cancer-related anemia in our country. But the literature flows from 40 to 80%, and definitely there is an increase in anemia with age, or malignancies like gynec malignancies, GI malignancies, lung cancer. And advanced cancer disease definitely have a higher risk of cancer-related anemia, which is the functional anemia or the anemia of chronic disease. And these are something which I thought probably before we jump into the topic, we should know that it is the diet which goes down, the diagnosis of malignancy, cancer, cachexia, and the inflammation which starts. The inflammation reduces the absorption. So from the entry level only, there is iron deficiency, or iron is taken but iron is not utilized. As we saw that certain malignancies come with the blood loss and it continues. Say rectal malignancy, throughout the treatment, you might see the up and down. During the metastatic rectal cancer treatment, you see blood loss. And certainly when we use the erythropoietin or stimulating agents, we will need more iron, and the anemia might become obvious. This is just was published in Annals of Oncology. This is a very important thing I wanted to highlight, that iron deficiency is quite common in the background. So the red bars are the anemia, and if you see the blue bars are iron deficiency. And different malignancies have different presentation. So sometimes some malignancies would present with anemia, but sometimes they may not present with anemia, but they will have a definite iron deficiency. Functional iron deficiency, we know that the TIBC, the iron saturation will be less than 20, but the ferritin levels will be very high, and the iron stores are high, but they're not utilized. I'll touch upon this topic in next few slides. If we look at this was a nice paper looking at the factors and cancer and inflammation, looking at the cancer-related anemia and the etiology. And these are the certain factors where I will like to highlight hepcidin is one of the factor, which is a kind of a target where we can look at it as a drug target to reduce the cancer-related anemia. And we also see reduction in erythropoietin and increased reactive oxygen species. These are the inflammatory markers we do see with cancer-related anemia. Managing this issue, most of the time we just look at the patient's cancer treatment, chemotherapy, other side effects, and when it drops down below 8 or 7, depending on the treating physician, we transfuse the blood. It is a very important aspect when we have a reflex mechanism to give IV iron supplementation or IV B12 supplementation, or for these patients who have anemia, but in spite of iron studies being normal, or there would be functional deficiency, but most of the time we do not pay attention to it. And that is a part which probably I like to highlight something here. Talking about oral therapy, is it useful for our patients? There are multiple oral compounds available. Issues are that the absorption may be affected with certain things, including our patients who have malignancy, GI malignancies, or those who have anorexia, they have chemo-related dyspepsia, constipation. They may not be comfortable using oral iron therapy. This is a time period which we all know that at least hemoglobin starts increasing from 3 weeks to 8 weeks. And this is a change we see, and we usually do not have time to allow a patient to take oral iron and wait for it. It's not that we have IV iron would increase the hemoglobin level quicker than the oral iron, but we do need to look at this aspect as well. So increased side effects and increased discomfort of the patient, and delay in improving the hemoglobin. So moving on, IV iron, I will not highlight so much in terms of the molecules available, but definitely I would say the previous molecule iron, IV iron available, they were associated with significant reactions, and they were not in favor, favorably seen into practice. But the presence of ferric carboxymaltose and iron isomaltose, these are the two IV preparations which are being compared right now, and which are being, we do use ferric carboxymaltose very frequently. Iron isomaltosides we have not started using, but there are certain benefits of this compound shown in certain studies. We need more data for this. IV iron along with B12 or folate supplementation would be a useful measure for those who obviously have blood loss because of their malignancy. And iron studies suggesting iron deficiency would be useful before we transfuse the iron. Now, usually we don't calculate the amount of iron required, and probably it becomes difficult in day-to-day practice. And there are certain flat doses which are recommended for 1000 milligram of NC-carb or ferric carboxymaltose, or whichever brand available. We do infuse the patient. And one important aspect is that we should never forget to add B12 or vitamin supplements and folate with this, because increased hemoglobin formation that would lead to macrocytosis because of relative deficiency of B12. And the drug iron isomaltoside has been in favor of because of this issue, where ferric carboxymaltose is known to cause hypophosphatemia, and this has been labeled as FGF23 syndrome. And there is this publication which I happened to read it like a while ago, and looked at these two drugs and compared these two drugs. And hypophosphatemia was definitely a commoner problem with ferric carboxymaltose, and which was not seen with iron isomaltoside. We will have to see the cost and benefit analysis, whether the phosphate supplementation would be a useful measure. Why it is so important? Because hypophosphatemia will also cause fatigue. The fatigue is because of the chemotherapy. The fatigue is also because of the anemia, which we are trying to correct with IV iron supplementation. So one of the cause we are trying to treat for the fatigue, and maybe we cannot create another cause for fatigue. And but obviously the drug right now is quite expensive compared to iron, our regular ferric carboxymaltose. And we will have to look at the pros and cons and the cost benefit in our country. Going ahead with IV, going ahead with the recombinant erythropoietin supplementations. And there are multiple options available, recombinant human erythropoietin, alpha, beta, theta, and these are all basically long-acting erythropoietin compared to like short-acting erythropoietin, the basic erythropoietin which was innovated earlier. And the half-life might go up to 24 hours for this because of the glucidic component. And there are other drugs, which darbepoetin alpha is also another very important recombinant erythropoietin supplementation, has been looked at by multiple studies. These drugs, I usually don't like to look at NCCN as such as a guideline when you look at the GI malignancies, but when I was looking for the more and more literature and the summary of things, and this was beautifully given in these NCCN guidelines. And I mean, this was something where I will like everyone to pay attention that the guidelines which talk about erythropoietin supplementation in cancer-related anemia, there is a lot of kind of restriction on whom to use in and whom we should not use. And one can directly go to the lower part of the slide, where the patient who is not receiving any therapy, or those who are not receiving myelosuppressive therapy, may it be curative or palliative, or the patient who are receiving myelosuppressive chemotherapy with curative intent. For example, we're using FLOT for stomach cancer, or we're using curative treatment for Hodgkin lymphoma, non-Hodgkin lymphoma, or breast cancers, dose-dense treatments with the curative intent. There is the enough evidence is not available to support regular use or routine use of erythropoietin stimulating agent. Now, in a non-myelosuppressive therapy, may it be curative or palliative, the studies definitely again do not support routine use of erythropoietin stimulating agent. For this, I was also going into details. What were the studies and why this controversies are arising? Because it's a drug which is useful when we can administer to a patient, the hemoglobin improvement might happen quickly, especially when we need quicker improvement in hemoglobin apart from the blood transfusion. And this is just a chart looking at the doses. Maybe we can just skip this. This is quite complicated, but I like this chart, and one can refer to the doses of erythropoietin and darbepoetin to this NCCN slide, because they have summarized all the doses very well, and especially those who are resistant. Say, for example, there is no hemoglobin improvement in 4 weeks with erythropoietin, or in 6 weeks with darbepoetin. These are called non-responder. What doses or how much you can go up. Why it is important? Because as we go up and with these doses we continue, the risk of thrombosis and the complications are also associated with these. So that is why it is important to look at the resistant pattern to erythropoietin stimulating agents. What are the ESMO guidelines talking about it? They indicate use of erythropoietin stimulating agent once you have corrected iron, B12, folate, and the other causes of anemia. The doses are by and large almost similar, but NCCN gives a detailed dosing, and I think what we routinely follow is the NCCN, what it mentions, the doses mentioned in the NCCN guideline. Now, I just wanted to highlight in the lower part of the slide where erythropoietin stimulating agent benefits and risks, and this was in I've taken it from the ESMO guidelines, and I like this summary of this, that there is a reduction in blood transfusion and improvement in anemia-related symptoms, fatigue, quality of life improves. How much it improves, we're going to go into detail some of the trials in a later part. But also, if you look at the risk and limitation, increased risk of thrombosis, and also increased risk of mortality or increased risk of possible hemorrhages have been shown in certain studies. If you look at blood transfusion, why am I comparing blood transfusion with erythropoietin stimulating agent? Because that's the next step. If the erythropoietin stimulating agents are not given, say Jehovah's Witness, there's a lot of data on this coming from the Western countries. We do have some people in our country, but definitely the data comes from the Western countries, or where the blood transfusion is refused by the patient. And what do you do? And the erythropoietin stimulating agent is the drug. And after that, if it is not working, blood transfusion is the modality to build up the hemoglobin. Now, blood transfusion definitely gives us immediate improvement in hemoglobin and rapid improvement in anemia-related symptoms. So, anemia-related symptom might marginally or say with a certain to the certain extent might improve with erythropoietic stimulating agent, but blood transfusion definitely going to give us significant improvement. Now, the blood transfusion associated infection or risk of thrombosis or transmission of pathogens, but probably and the overload, but probably with the improved technique with Paxil and leukodepleted blood transfusion, I think these risk factors may not be very significant right now. These are all taken from the studies which have been done before 2015. This is one important study which I like to highlight, which was published in, this is basically a systematic review and meta-analysis. And this is included 37 randomized controlled trial and 10,581 patients. When we look at the conclusion, it talks about that there was significant improvement in anemia-related symptoms and patient quality of life, which was assessed with fact AN, anemia, had shown improvement, but these were marginal. And if you look at fatigue-related symptoms, fact F did not show much of benefit. Why am I showing this meta-analysis? Even though this is a positive study, positive outcome shown by this meta-analysis, the impact is small. And the next comes is this Cochrane meta-analysis published around same time and talking about and this paper is quoted and cited many times. This was published in 2012, and this was the paper which actually brought a lot of issues about erythropoietic stimulating agent, about the thrombosis risk, deaths, increased mortality, and possible increase in the tumor progression. Going ahead, I looked into multiple studies. One should understand all these studies have been done in the range of 2001 to 2012, and only right hand side, lower right hand side is a radiotherapy study which looked at it was 2018 study, and all these studies are randomized trials looking at 300 to 700, 800 patients. And these all studies have shown a decrease in the survival in terms of overall survival or increased mortality because of thrombosis or complications or loss of tumor control. There are some, this clinical study which is published in Lancet looked at head and neck cancer patient undergoing radiotherapy, and local control was lost in the erythropoietin arm. These are few more studies, and these are also looking at darbepoetin. And these studies showed decreased survival. Now, there is a controversy. Few studies which were done in 2009, 2010, 2014, and 2011. These are the studies which we again randomized studies and two meta-analysis. They showed that there is no impact on the mortality or the disease progression with the use of erythropoietin stimulating agents. So, with all these controversies, what I would look at it, I looked at the studies where if you see the left-hand side of the panel, the target hemoglobin of these previous studies were the hemoglobin should be more than 12. Now, thinking that if we improve the hemoglobin, there will be a better outcome, better results with radiotherapy, better results with chemotherapy. There's a cervical cancer trial, head and neck cancer trial, or lung cancer trial. And those trials who looked at hemoglobin more than 12 as their primary endpoint, there was increased risk of thrombosis, increased mortality, decreased overall survival in terms of the tumor response, and decreased tumor control. Now, if we look at the right-hand side panel, these were the studies which were creating the controversy. They did not look at the target of increasing the hemoglobin more than 12, but they looked at avoiding the blood transfusion or improving the quality of life. And these would also include the meta-analysis. So these studies did not show any impact on the overall survival or disease-free survival the reduction in blood transfusion requirements were significant, and marginal betterment in quality of life in terms of fatigue, reduction in fatigue or anemia related symptoms. Now with all these controversy and all that, one thing I like to highlight, those studies who have looked at quality of life and reduction in blood transfusion and target hemoglobin was not 12 and above, you cannot completely exclude overall survival or disease-free survival impact. They have these are the they have not looked at this primary endpoint as survival, but these are subgroup analysis, post hoc analysis, and these analysis were suggestive of no impact, but you cannot completely exclude the impact. Now, what I after going through these multiple articles and also the discussion we usually have, one should probably wait for further studies, and those who are specifically looking at the survival outcome as primary endpoint and using erythropoietin stimulating agents. Now, does that mean that we should never use erythropoietin stimulating agent? We should just avoid, or what are the areas? FDA also in 2017 they came up with their assessment, some way of analysis, and then there is a FDA website also mentioned this, and they added a black box warning with a revised FDA label for ESS, and they avoided they summarized that it should not be used when the intent of treatment is curative, and when the intent of treatment is palliative but it is non-myelosuppressive therapy, and intent of treatment is palliative and the patient receives myelosuppressive therapy, you can consider ESA, erythropoietin stimulating agent, but blood transfusion, use of clinical trial or other modalities trying to correct the anemia, I mean, these are the modalities they would prefer before erythropoietin stimulating agent. So that leaves us with, okay, there is not much of scope of erythropoietin stimulating agents. So before going ahead, I will just like to, like this is the last part of my topic. We are working on a clinical trial on this topic. So apart from erythropoietin stimulating agent, I was looking for some more agents which can be used to improve the hemoglobin. And this is the mechanism where we definitely have 10 to 20 milligram of iron per day in our diet, and the absorption is 1 to 2 milligram, and the loss is 1 to 2 milligram. And this is the where enterocytes absorb the iron, and then with ferroportin and transferrin carries the iron to the reticuloendothelial system to go ahead with formation of hemoglobin. Now, liver plays a very important role. And if we see, there's something which is hepcidin I talked about in the beginning of my talk, where hepcidin inhibits ferroportin. So absorption of dietary iron is reduced because the enterocytes are saturated with iron, so they refuse to take further iron. And hepcidin also inhibits ferroportin 1, where the iron is not delivered to reticuloendothelial system. Now, with all these, if this hepcidin is removed, do we probably allow iron to get absorbed and to be utilized to form the hemoglobin? That's a very important question. And this drug, lactoferrin, is also available in one brand name Ferronemia, where it works to it actually inhibits. It is a transferrin group of family protein, and it has very high affinity, almost 300 times higher than the regular transferrin. Now, what happens is this hepcidin and this transferrin, the hepcidin related inhibition of ferroportin and transferrin, where this lactoferrin might attach to the iron and carry the iron to the reticuloendothelial system and might improve the hemoglobin values. Now, this has been studied in certain there are very few studies in terms of oncology trials, but this molecule has been looked into by the nephrology units, nephrology trials, and especially in chronic renal failure patients. And we are also initiating a randomized trial using the molecule, and hopefully we without erythropoietin, if we are able to improve the hemoglobin by 1 gram, that is what we are looking at. The study will initiate soon. That's all what I could look at, and I could see that we can add to this cancer-related anemia. Obviously, blood transfusion and all those aspects are part and parcel of our treatment, and iron infusion is part and parcel of our treatment. About erythropoietin, probably we have to be very careful, because FDA or guidelines, NCCN guidelines, restrict us from using it to every and other patient. Looking at the lactoferrin like drugs would be very useful, especially when we are dealing with the functional iron deficiency anemia. That's all about cancer-related anemia I wanted to speak today. I am happy to take the questions.
Thank you, sir. That was really informative. I mean, you covered the entire topic from pathogenesis of cancer-related anemia until the management. You discussed about the controversies also. So it was really excellent to hear from you. So now the discussants, I will request one by one to unmute themselves, and they can discuss their cases with Dr. Vikas Oswal. So I'll start with Dr. Soumya Surat Panda, and then subsequently we'll take it. Anita, if there are any questions in the chat box, please share it with me so that I can take them also in between. So now we will unmute Dr. Soumya Surat Panda to ask his questions.
Thank you, sir. I think that was a very wonderful talk, and almost all the relevant points were covered. So, sir, just one question I would like to ask. A patient comes to you in the OPD, the GI, advanced GI malignancy, and patient is having hemoglobin of say 9, and patient you have found out that is iron deficient. In that case, what is the iron formulation that you would like to give, and how do you choose and judge based on the iron isomaltoside versus ferric carboxymaltose? So, what is the one that you prefer, sir?
Yeah, thank you for that question. And I think we have to go as per our formulary, and we have ferric carboxymaltose as of now, and we've been using that as the drug of choice for all our patients with iron deficiency. Iron isomaltoside is actually probably. I mean, I found that the literature was useful, and I would like to use that drug. I've not used as of now, to be honest, and because it's not available in our formulary. But once available, definitely I would like to give that option. Hypophosphatemia was a very significant problem, and I think the fatigue related to hypophosphatemia we do face any which ways because of the nutritional phosphate deficiency.
Yes. Or between the oral formulation and the IV, so do you feel, because there are some trials or there are some studies to say that even the IV formulation does produce GI side effects, but is it easier? Do you feel that easy? Because we have found it easy to give IV formulation rather than oral formulation, because patients, they do complain about the GI side effects with the oral formulation.
Definitely, IV formulations are easy to give compared to oral, and our patients do come back with a lot of dyspepsia, and they usually don't tolerate oral iron somehow, especially with the GI malignancy, and also we cannot differentiate between the melena and the oral iron causing the black stools in luminal malignancies. That helps, like one time you give. They also have to take multiple medicines along with the chemotherapy. So if you give one time IV iron, at least I'm looking at iron isomaltoside, which is a one time, that's what they claim. Probably it will be useful.
Yeah, thank you for your answers. We'll move on to the other discussions.
So thank you there. So we next go to Dr. Asutosh Panigrahi. He's associate professor in the Department of Medical Oncology, Hematology. at AIMS Bhubaneswar. Sir, over to you.
Am I audible?
Yes,
Am I audible?
please. Yeah.
Okay. So nice discussion. Basically, we get referrals regarding management of anemia during solid malignancies or other tumors. Basically, we deal with anemia related to hematological malignancies. This scenario is something different when we deal with hematological malignancies, especially with bone marrow involvement. But whatever consults we see, my question is, Dr. Vikas, do you practically feel hypophosphatemia is a major issue in IV iron? Because left and right, I'm using ferric carboxymaltose. Okay, I especially concerned about hypophosphatemia in two conditions. One is when I'm giving to a child, and second, elderly patient, and those which are nutritionally very compromised. Otherwise, I have never faced a condition of hypophosphatemia after giving a ferric carboxymaltose. Number one. Number two, my question is how you are scheduling a IV iron when you are giving it as a therapy for iron deficiency in solid malignancies.
So I'll answer the first question first. See, to be honest, I don't think that I am checking phosphate in each and every patient when whoever is receiving chemotherapy. I think our focus is probably just on CBC and the renal and liver function at max. And in that, we don't look at it. And probably the patients have fatigue. And sometimes if we have done the entire panel, calcium and phosphate deficiency, now since we started looking at this hypophosphatemia was brought, phosphate deficiency is there. Now treating these patients with whether the fatigue improves, but when already these patients have other reasons for the fatigue, it's a very difficult question to answer. And I think we probably need a systematic evaluation using the fatigue and fact anemia, and then look at correction of fatigue phosphate level. The study which was talking about ferric carboxymaltose versus iron isomaltoside, they looked at the levels of phosphate and then they compared. But yes, I agree with you. I mean, it is whether it is going to impact our day-to-day practice or patient symptom, we have to see. There are many other causes. Our patients are nutritionally deficient compared to the Western population. And we all know that their nutrition profile is different than our patients. I completely support your point, and I think we should look into it rather than just jumping on it. And that's another reason we are very careful before using the drug, adding another level of cost to the patients. The second question, can you please repeat?
That how you schedule basically. Suppose multiple cycles you are giving before starting your treatment, you give, and at the end of treatment you will give, or at best how you are going to monitor. Yes, my IV iron is working, or I need to address any other issues. That is my intention.
So we have two sections actually: resource limited and not resource limited. And not resource limited, we do iron studies and all that, and supplement at the beginning of the treatment. But those who are resource limited, we just look at NCV, RDW, and supplement iron and vitamins. Now, like going ahead, we do look at the hemoglobin, and we do check, say 2 monthly or 3 monthly or 4 monthly iron studies, and we look at the deficiency. Now that is the whole reason I am actually looking at the study which is based on lactoferrin, where these patients actually have functional iron deficiency more than the actual deficiency of iron once you're supplemented in the beginning. So once you're supplemented, that's not a major issue unless it's a rectal cancer patient who continues to bleed. So there on follow-up, if you ask me to make it very simple, once you're supplemented at the beginning, iron deficiency may not remain a major problem, but the functional iron deficiency and anemia of chronic disease would remain a major problem for us.
Thank you, sir. Thank you.
So Dr. Vikas, if I can just ask you once, so I mean, do you routinely perform this iron studies and vitamin B12 folate levels at the start of your therapy, or how is it? It's a protocol?
In resource adequate situation, we do perform, and we look at transferrin saturation, and that's what we use actually, rather than any other I mean parameter. The transferrin saturation actually helps us a lot, and most of the studies have looked at transferrin saturation.
Thank you. So we'll now go to Dr. Priyanka Samal. So she is professor in the Department of Hematology at IMS and Sama Hospital, Bhubaneswar. So, madam, over to you.
Thank you, Dr. Saurabh. Thank you, Dr. Vikash. I'm audible, I suppose.
Yes, yes,
Uh,
yes, you're audible.
Yeah. So one thing I would like to share over here, we have had an experience of isomaltositose as well. It has been available with us in India. So almost both of the drugs have similar efficacy, but isomaltositose, I think I'm able to give it in 15 minutes. For carboxymaltose, we give it for a little bit longer time, but that is very subjective. I wouldn't say that makes a big difference. Very true, we have levels either prior to or after giving the iron. Fatigue is one of the complications, because I am talking about deficiency anemia, because you use it mostly in patients where there is cancer associated anemia. Fatigue is not a cause of. So fatigue is one of the side effects. I will not deny that, but we do not look into the phosphates. Rather, it goes away on its own if the patient takes a little bit of rest or something like that. But Dr. Vikas, I would like to have your opinion regarding, you mentioned about functional iron deficiency. So how do you manage a patient with functional iron deficiency, and how do you monitor it? And till what level you continue with your therapies?
Well, I think we keep the threshold for transfusion below 7 in most of the younger patients, and for elderly patients or high risk patients, this is been defined high risk like cardiac issues or pulmonary issues. We keep threshold of hemoglobin of 8. Apart from that, use of erythropoietin stimulating agents I have used in certain patients who are refractory and whose hemoglobin is definitely interfering with their chemo frequencies, like intensity and density, so that they can continue the chemotherapy. But we definitely restrict the use of ESAs in palliative setting where the myelosuppressive chemotherapy is being given. So something which is as per the guideline. So I'm say triplet drug of chemotherapies and triplet regimes, and certain small cell carcinoma where those trials have not shown any adverse event or in terms of survival or in terms of increased thrombosis. GI malignancies definitely have higher risk of venous thrombosis as per the nature of the GI malignancy, and especially in the advanced stages. So we are and we use a lot of platinum. So we are really concerned about venous thrombosis. So adding to it with the help of erythropoietin stimulating agent, we are careful. But one important aspect is that the moment hemoglobin touches 9 and above, we definitely stop. We don't give it more than that. We're not expecting the hemoglobin to be 11 or 12 or something like that. So that's something, a key factor which helps us not to have patients with coming back with thrombosis or other complications.
So how is the dosing?
I'm sorry, your voice is breaking. Dr. Priyanka, I couldn't hear you.
So, Dr. Priyanka, can you please say about, I mean, you're asking about the dosing, I suppose, right? You're not able to hear you actually.
Yeah, am I audible?
Yeah. Now it's okay. Yeah.
They ask, like, for patient, use
It's still
ESS and
breaking.
IV iron. It has come up to 9.
Yeah.
It's
IV
still
iron.
breaking.
So
Yeah.
he's saying that IV iron has
I'm
been,
sorry, you can
yeah, it has come up to 9 hemoglobin. After that,
make.
so,
Would you like to maintain it with a dosing like 2 weekly or 3 weekly schedule? Over there, you have reached, and if it falls again, like it is try to maintain.
so I think what she is asking is that if it gets back, if the hemoglobin reaches to 9, would you just continue using the ESAs so that it doesn't fall down? Because once the hemoglobin falls, so yeah.
No, we stop those drugs, and we just wait for the patient to actually have another episode, and then we'll again react. But we definitely don't continue. And also the studies have shown that longer duration, or that's the controversy, where the increased risk of thrombosis and inferior outcome. So we don't push the patient into those controversies.
Thank you. So thank you, Dr. Priyanka, and here. So we have an audience question. I mean, maybe we can just take it. So what all other laboratory investigations do you use to detect the anemia in cancer-related patients other than hemoglobin? I think you can take it, Dr. Vikas.
Yeah. Shall I take that question?
Yeah, please.
So in not resource limited situation where we have resources and patient is willing to get this test done, so we do iron studies, iron, TIBC, ferritin, B12 level, folate levels, and uh, we usually don't look at LDH and all that, because this also be biased by the disease. So these are the markers when we look at, apart from hemoglobin, MCV, RDW, and platelets and counts.
Thank you. So there is also one question, I think here, how often do we calculate iron deficit by the Gangioni equation? Is there something like that?
Sorry for the background. The formula we usually don't use, as I mentioned, most of the time we give it by default.
Okay. We don't use it. Okay. Thank you. Thanks, Priya. So next we'll
Can I say
please,
something in this
yeah,
situation?
please, Dr. Asutosh, please.
Yes. So my approach is, when we get a patient of anemia, after taking detailed history and clinical examination, finding out what may be the possible cause of this anemia and the drugs the patient has been treated. This is the most important part in assessing a patient of anemia when associated with any malignancy, whether it is hematological, non-hematological, whatever may be the issue. This is the most important, because that gives a clue how you are going to approach this patient. Second one, erythropoietin stimulating agent is a option. So before jumping to erythropoietin stimulating agents, we have to exclude all other causes of anemia. If those are there, we have to treat by that, and that will improve the anemia. If it is not an option, then we have to go ahead. So my opinion is, if at all after it is backed by history and clinical examination, I will go ahead with iron estimation and all iron parameters, because that will give you a clue whether it is a um, um, pure iron deficiency or a functional iron deficiency. And B12 folate, these reports are really very worrisome. Many times you will have a false report. So if you are giving a folic acid tablet to any patient, I don't think there will be any harm if you are not doing a investigation. But B12, I think if clinically indicated, then we should go ahead with bone marrow evaluation and timing during the treatment or after completion of treatment, when the patient is having anemia and how long it is persisting. Based on that, we can act. And regarding this formula, it is only in non-malignant patients, it is mostly useful. In malignancy, we give a flat dose. Yes, it is either 700 milligram or 1500, and repeat again when required, as Dr. Vikas also has rightly mentioned, that it is not a routine that we'll do, but when it is indicated, we'll go ahead with evaluation. and treat accordingly.
Thank you. Thank you. I think you have highlighted very salient points, which Dr. Vikas has also elegantly described. So now we'll take a question from Dr. Prashant Kumar Parida. He is an associate professor at Acharya Harihara Medical Cancer Institute at Cuttack. Sir, over to you.
Thank you, Dr. Vikas, for a wonderful presentation. So my question is regarding the use of erythropoietin stimulating agent, especially though most of the guidelines they recommend, especially patients on myelosuppressive chemotherapy in palliative intent, we can use these agents after excluding deficiency anemias. So especially the drugs like CDK4/6 inhibitor, which we use in hormone receptor positive MBC, or the PARP inhibitors like olaparib. We have seen several patients having significant anemia. So what is your opinion regarding use of ESA in this type of situations?
So essentially, I think when the trials happened, all these drugs were not available. Most of the trials are talking about the chemotherapy drugs, and the guidelines, including the FDA label, all that they mention is that for oral hormonal therapy or oral therapies, do not use ESA. Now, I don't think we can definitely apply, and I get your question because these drugs are new and going to cause significant anemia. And I think we will need more data or studies on these. It still remains controversial, or maybe careful use and selection. And what they have defined into in metastatic setting, myelosuppressive or non-myelosuppressive, that kind of division, if we use, probably we are in the safer zone till we get further data.
So have you ever used ESS in this type of situation in your practice?
I had happened to use CDK4 inhibitor only once, that too in an NGS report showed something in my GI malignancy. I would probably not, I'm not the correct person to talk about this drug, which is not my routine practice. I look at GI malignancies alone.
So Dr. Vikas, maybe if I can ask, what do you think, what is the reason for these erythropoietin stimulating agents causing a disease or cancer progression, increasing mortality? So do you think it is only thrombosis, or is there any other cytokine milieu which comes into play? That's something which would be interesting to know.
Yes, and that's a very good point, because when I looked at the detailed analysis of the meta-analysis plus the articles the published looking at these malignancies, the increased mortality could be there could be two reasons. One is increased thrombosis or hemorrhages, thrombotic hemorrhages, and the other thing would be the disease progression. Now, there is definitely the cytokine milieu or unknown reasons. I mean, many guidelines mention that the reason not defined or unfound, but they have the data shows progression. And I like to highlight here that even the GCSF has similar data, controversial data, and stimulating the mother stem cells of the tumor and the milieu around would probably be the factor we should look at. But I think data is not that strong to kind of come to a conclusion. But that's a very good point.
Thank you. Thank you. So basically, we now have two questions we would like to take from the audience. One is that, do we need to document, this is from S. Venkat Kiran. He's asking, do we need to document serum erythropoietin level before starting ESA in cancer-related anemia? That is one question. And the other question is from an anonymous attendee. He's asking, how do you choose between erythropoietin or darbepoietin in your clinical practice?
The first thing is that we don't do erythropoietin levels. We know that it is, I mean, it is proven that the levels are low, or the situation is where you have adequate iron and you can't utilize it. So like nephrology colleagues, we don't do it. They do it and we don't do it. And the other thing is, other question was the selecting between erythropoietin or darbepoietin.
Yeah.
I think darbepoietin can be used less frequently than erythropoietin. That gives us comfort where 4 weekly doses or 3 weekly doses. that probably gives us a comfort zone.
Thank you. Thank you. So we'll now go to our next discussant. We have Dr. Jogmaya Patnaik. She is Assistant Professor in the Department of Medical Oncology at KIMS Bhubaneswar. Over to you, Jogmaya.
Hello, good afternoon. Am I audible?
Yeah, yeah.
Yeah, thank you, Dr. Saurabh, for this opportunity and very nice and elaborative talk by Dr. Vikas. So I had my thesis in my DM that profile of anemia in patients who are like ALL patients who were treated with cytotoxic chemotherapy, and we evaluated that there are in those patients there are deficiencies of vitamin B12, iron, and folic acid found, and if we supplement that, the quality of life and the anemia improves, and also their outcome was improved because the study was short. So we could not show that the survival benefit and all were there, but definitely the clinical improvement in the level of anemia was associated with better quality of life and compliance to treatment. So definitely the treatment of anemia in cancer patients carries a very important prognostic and prognostic factor, and we use quite a lot erythropoietin and darbepoetin, as Dr. Vikas currently has just before has told that darbepoetin is less frequently used, so it is comfortable. We are comfortable in using it, but the cost is like very high compared to erythropoietin. Like you give erythropoietin weekly, the cost compared to darbepoetin, which is given 3 weekly or 4 weekly, the cost is I think 10 times high. So that is a catch of using those two drugs. Another thing, my question to Dr. Vikas is that, do you use erythropoietin stimulating agents in multiple myeloma? Because in multiple myeloma, we face anemia a lot. Like Dr. Ashutosh has said that in hematological malignancies and all. So is it you?
Dr. Vikas actually he deals only with GI malignancy, so he must.
Oh, I'm sorry. I'm sorry. Okay.
Maybe Dr. Ashutosh can tell us what is
Yeah.
it. Yeah, Dr. Ashutosh, Dr. Priyanka, you guys can please take it.
Yes, fine. So anemia in myeloma, really, you all agree that it is not a single factor that is contributing to anemia. It is multiple factors. Initially, we start with if the patient is very sick and we need to start treatment, then we transfuse so that we can start our treatment as early as possible. We see the response. If it is persisting, then we think of finding out what is the cause, and accordingly we treat. Yes, when we fail, we evaluate all causes of anemia. We started our treatment, disease is controlled, but still anemia is persisting, because once you start the treatment, the anemia will get corrected for multiple myeloma. And as long as disease is there, probably you will facing the problem. And the drugs, of course, lenalidomide and all myelosuppressive drugs, if you are giving, then that may cause anemia. And after all this, if it is still low, then yes, I use erythropoietin stimulating agents. My experience with the darbepoetin is very less. I always use erythropoietin, and my start dose for multiple myeloma is around 10,000 bi-weekly or weekly or bi-weekly, and see the response. And if at all it is suboptimal, I can schedule my dose as per the requirement. Of course, I closely monitor these patients for thrombosis or adverse events due to erythropoietin stimulating agents. But my use of erythropoietin for multiple myeloma is very less. Those who are not responding and with significant renal impairment, I do go ahead. Others can give their input.
Okay, thank you, sir.
Saurav, if you have time, I can just.
Yeah, we'll have one or two words. I will like to hear from you, please. Yeah.
Yes, so we use erythropoietin. My choice is darbepoetin because it is convenient for the patients. And second is, only if a patient has achieved a CR, documented CR, you have excluded other cause. It is because of lenalidomide. I usually change over to thalidomide if there is persistent anemia. If the patient is not tolerant to lenalidomide, having lowering of counts, because these patients, when they are on immunomodulators as well as DEXA, they are prone to thrombosis. So most of the time I prefer from len to go back to thal if the patient is tolerating it well. And on len, suppose thalidomide, many people have neuropathy, you are not able to change it to thal, then in those cases only we go for darbepoetin or erythropoietin, whichever it is up to the physician's discretion, whatever he is comfortable with. So that is how we treat our patients for myeloma with anemia.
Thank you, Dr. Priyanka. I got my answer because I always wondered that we use mostly the drugs which can cause thrombosis, and will the use of erythropoietin stimulating agents will cause more thrombosis in this group of patients? That was the point why I asked this question. Another point.
Can I add something? Can I add something?
Please.
Yeah.
Dr. Jogmaya, if you are worried about risk of thrombosis in myeloma, then there is a beautiful article you can go ahead in Blood. So there they have very nicely described regarding the risk of thrombosis in myeloma. So it is mostly in early part of the disease. Once the disease is controlled, or even if the disease is relapsing, the risk is very less in comparison to initial treatment. Number one. Number two, they have a 8-point scoring system. If the score is less than 5, don't worry about the thrombosis. It will very unlikely you will have thrombosis. Okay. So that you can follow.
So that brings me to the next question to Dr. Vikas. So in your clinical practice, we would like to know two things. What are the common toxicities which you face? I mean, you would be using ESAs at least in some patients because the burden of patients is very high. So what is the common toxicities, especially with regards to thrombosis and other toxicities which you find with erythropoietin stimulating agents? And second part with the iron therapy, what are the common toxicities which you find?
I would say the use is very less. So to define the toxicity, I think I should give a good number and then only come to the toxicity. But I haven't seen toxicity because number is less. And IV iron, we've seen few reactions, but that's very less than 1%. Apart from that, patient definitely, as you mentioned in the beginning, patient might face some GI disturbances, dyspepsia and abdominal discomfort. A few patients had come after the IV iron supplementation. There are different formulations which are available, but I think vomiting and diarrhea were also seen with certain formulation, which were used when our regular formulation was not available. So, and we had to actually stop that drug. I would not name it here, but essentially we saw almost 60 to 70% patient coming with GI toxicities after that use of that formulation. But the regular one, what we are using, by and large, only few reactions we have seen.
So is there any recommendation that if you are using erythropoietin stimulating agents, other than the baseline risk of thrombosis from the cancer per se, if at all, is there any recommendation if you are using ESAs, then you need to give thromboprophylaxis? Because the incidence is pretty probably, according to literature, it's sizable.
I didn't see any article or any meta-analysis or any recommendation talking about it. Maybe I missed it, but I don't think I saw anything like that. And also, I will be more worried about the additional bleeding or something like that. I mean, especially when I look at my GI malignancy patients, luminal malignancies. But to be honest with you, I don't think so. I've seen any mention of that. Oh, that's a good point. We can look at it.
Yeah, so maybe we can look at it. So we have now Dr. Biswajit. He is an hematologist, assistant professor in the Department of Hematology at KIMS. So Biswajit, over to you for your question for Dr. Vikas, and thank you for joining.
Hello, so I am audible?
Yeah, Biswajit, you are very much audible.
Thank you, sir.
Yeah.
So my question is, so what is your practical experience of finding this thrombotic microangiopathies and hemolytic anemias with these chemotherapy that are conventionally used for solid tumors? So what is your clinical experience about that?
So basically, Dr. Biswajit is asking if at all we see microangiopathic hemolytic anemias with solid malignancies or with the chemotherapies which we are using in the solid.
Right.
Well, we do see a lot of thrombosis. I don't think that the paraneoplastic or microangiopathic hemolytic anemia are so common, or we don't actually, it may not come up so much with us. I don't think we would be able to even define that whether we really have a bigger experience about it.
So Biswajit, do you look for that in your patients? I mean, other than the workup, how do you learn?
Sir, recently I have encountered one case of adenocarcinoma of stomach with this thrombotic microangiopathy. So that's why I was asking.
So how did you diagnose actually the thrombotic?
So actually, means the anemia is there, and the peripheral smear was showing a hemolytic picture. So the unconjugated bilirubin was elevated, and cystocyte percentage in the peripheral smear was around 2%. And LDH was also raised. So that gives a clue regarding the development of microangiopathy.
So was he on any of the chemotherapeutic drugs, or it was?
I think he was previously receiving this chemotherapy with these platinum compounds, and the rest of these platinum compounds and capecitabine. So with this chemotherapy, and he was not using any checkpoint inhibitors or any immunotherapy actually with this conventional one.
So I think that's an interesting observation. So at Dr. Vikas,
Right.
this is very rare. I mean, we also haven't seen in our practice like GI malignancies having this microangiopathic, but at least if at all we have a picture like as you are saying, we should look for that, right?
Right, sir.
Yeah, thank you. Thanks for it. So I think we don't have any more questions here, and if there are any other comments, you'd like to take it. If not, I would like to once again thank Dr. Vikas for taking time out of his busy schedule. We have been in touch for like the last 5-6 years, and he has been very, very active in GI malignancies, and especially with the improvement in outcomes in the Indian context. They have a lot of data. Dr. Vikas and Dr. Anand, they do work very beautifully, and is also a part of the IASCC, which is the supportive care in cancer. And as discussed, it's a very neglected area. So I would also like to thank all the discussants here who have beautifully discussed this topic, and all the delegates who have participated. Please collect your certificate of participation. And I would like to thank Anita and all the Sambit and all Rudra from members from IAO who have actually made this webinar a successful meeting. So thank you once again, everyone. And if there are any comments from Dr. Vikas or anyone, or else, thank you. Thanks.
Thank you, Saurabh. Thank you, Dr. Vikas.
Thank you so much. Thank you, Dr. Saurabh Mishra. Thank you, Dr. Soumya Panda. And thank you, Bhubaneswar team, for this wonderful session. I really enjoyed it.
Thank you.
Thank you, sir, for this wonderful discussion.
Thanks.
Have a nice weekend.
Thank you. Same to you.
Thank you, sir.
Bye.